welcome everyone to another episode of Three Plastic Surgeons and a Fourth with my fellow co-hosts. As always, it's Dr. Lawrence Tong from Toronto, Canada, Dr. Salvatore Pacella from San Diego, California, and Dr. Sam Jejurikar from Dallas, Texas. And today, our topic is a very interesting one. It's one where I know that none of us have difficult patients. All of our patients are perfect. They are the best patients that we've ever seen. But if you know someone who might be, a physician or maybe a friend who might qualify as, a difficult patient, um, there was a great article in Doximity where they talked about five foolproof strategies for dealing with difficult patients. And this is something that even if a patient isn't necessarily difficult, it's really about communication between, say, a surgeon and a patient. And so let's delve into what those things that they suggest might be, and whether they can help uh, patients, whether they can help doctors communicate better for all of their interactions. But before we begin, let's start with the disclaimer, please.
All right. This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for information purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health professional with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something on this show.
Thanks very much. Now, I was kind of being facetious when I said none of us have difficult patients. I mean, patients are people, and there are all sorts of different people out there. So, what would you say? Let's talk a little bit about your own experience with difficult patients and how you might sort of identify them or manage them over the years that you've been a plastic surgeon. Sam, do you want to start?
Yeah, I think, first of all, I think when we use the term difficult patients, that already sort of sounds a little bit prejudicial, right? Generally, when as surgeons, we have interactions occasionally with patients that become difficult, but usually there's been an outcome that doesn't match what it was that they wanted, or they've had a complication that wasn't foreseen, or the recovery was different. There's usually something that didn't go in the way that the patient was expecting. That is usually the impetus for this breakdown in communication between the surgeon and the patient. And patients are human beings, surgeons are human beings. We all have emotions that we bring to this, which can sometimes cause these things to break apart. And so, I think when I have a patient that's upset, I feel like I'm a lot better at listening to what it is that they're upset about now than I might have been 10 or 15 years ago. When I try to remind myself that maybe it's not meant to be a personal affront, it's not meant to be a personal, personal a personal insult towards me. They're just trying to voice their own. They want to be heard in a way that that's productive, that may or may not be productive. But it's my job as a surgeon to try to make sure I hear what the underlying root causes are, let them understand that I understand where they're coming from and what's wrong with them, and then see if we can come up with productive solutions.
I kind of separate this in my mind into three different categories of patients, I would say. The first category are people that I meet that I know at the end of our consultation that it's a good fit for me to be their surgeon. I can't provide them the best expectation that they're looking for. And in my mind, that's easy because it's just, we just part ways. There's no animosity. However, I will say that over the years, I've gotten a handful of bad reviews, and 90% of them were from people that I didn't operate on, that I told no for sure. Right. So I think it tells a lot when you do a bad review on somebody when you haven't even touched them. So it's probably somebody I would, in retrospect, still not operate on. Right. The second group of patients are patients that have an unsuccessful or unfortunate outcome or complication. And to me, I'm always surprised at how well patients are able to take that complication. And I think a lot of that has to do with the fact that, we spend a lot of time in the informed consent process. I have great nurses and great staff that set expectations. And, I was always told by my mentors, which was a great bit of teaching, that if somebody has a complication, you see them until they're tired of seeing. Okay. And, I want them to know that I'm very attentive to their complications. And I would say a good majority of those patients really are understanding. They're sort of, are able to deal with the ramifications of the complication, kind of stick with me through the process of attempting and fixing the complication. Right. And then there's a group of patients which are completely unpredictable. And, if you look at a graph of grafting the complication versus the perceived reaction, that's sort of, you would think that would be a linear graph. It's actually all over the place. And I always really take, I'm on alert when I have a patient that exceptionally praises me for my surgical skill. Okay. Because a lot of times patients will come in after their operation 6 months, a year later, and they'll say, Dr. Pacella, you are just a godsend. Your hands should be blessed. And it's just amazing. I'm so happy that you came into my life. And I thank them and I really appreciate it. But I, in a good group of those patients, other foot has dropped very quickly. And those patients have focused on a small scar, a small untoward outcome, a small asymmetry, a small lid malposition, and they can turn very, very quickly. And the problem is I'm not really able to tease out who those patients are going to be ahead of time. So
I do think many of those patients are probably the same people that when they come see you for a consultation are the people that will spend time bad mouthing another provider,
which is a huge red flag for me because I would, it's very rare that I would operate on somebody that actually does that to me, or that mentions that in the consultation. That's a huge, huge red flag.
Yeah, I think that cosmetic surgery is one of the unique situations where, it's okay to reject a patient. So part of managing the difficult patient is to identify the patient, first of all. And if you as a surgeon don't feel comfortable or don't think that you're going to get a good outcome, no matter how good the surgical result is, then I think it's important, to tell the patient that, like what you both said, it's not going to be a good fit and it's not going to work out. And to Sal's point, when somebody does have a complication, they have to know that it's going to happen at some point. If you operate enough, you're going to get complications, and it's not the issue that you've had a complication; it's how you handle it afterwards. And so, seeing the patient very often, reassuring them, doing the right thing is going to be the best way to manage those situations.
Like Samir, what did Bill Kuzan teach you about being board certified in plastic surgery and complications?
Being board certified in plastic surgery.
No. Come on. Do the voice. Do the voice.
Being board certified in plastic surgery makes you qualified to make mistakes in plastic surgery. Meaning that we shouldn't dabble outside of what it is that we do. But, I think what you guys are saying about how to manage complications is 100% correct. When you have a complication, it is a huge privilege to operate on people. And we have to, part of that privilege, it's our responsibility to get them through any sort of consequences that were not anticipated or foreseen. It's just that sometimes every now and then, maybe once every couple of years, patients take that complication and they make it as though you did something wrong. And that's when, in my mind, they become a difficult patient. I don't view a complication as something that necessarily makes someone a difficult patient. It's the reaction and when the relationship between the physician and the patient can break down.
Listening to all three of you, go ahead.
Sorry. For the patients out there, I think that are listening here, I think it's important to articulate something very clearly. Complications are something that we absolutely 100% dread as surgeons. If you don't care about your complications, you probably shouldn't be operating. You probably shouldn't be caring for people. So the last thing we ever approach is a cavalier attitude toward complications. In fact, when I get a complication, it's something that absolutely keeps me up at night, and more importantly, wakes me up in the middle of the night that I can't get back to sleep. So, I mean, these kind of things just fester in your mind as a surgeon constantly. And, it's like the old, ABC World of Sports on Saturday afternoons when I was a kid. It's the surgery is all about the thrill of victory and the agony of defeat. And it goes back and forth every minute. So it is something that gnaws away at us.
I think listening to you three, a couple things stand out for me. One is, as we get older, we get more experience with both successes and our failures or our mistakes, and we don't want mistakes anymore. We've gone through all that. We are very. I think all of us are much more careful in terms of evaluating patients, and if we don't feel like either we're going to get the right result for the patient or the result that the patient is really looking for, as Sam said, we're gonna Sam and Sal said, we're gonna pass on that patient, because what we're really looking for is to minimize our risk in terms of, as you said, a negative outcome or consequence, regardless of whether it's uh, technical or just not meeting the patient's ideas and goals. Uh, I'm so much more selective now than I ever have been. And I think most surgeons, as they become more experienced, do that. The second thing is a lot of this is about evaluating a patient and, like you said, being compatible. Different surgeons have different personalities, as you mentioned, different styles. And I want patients who are compatible with me. And if I feel like they're not, then then the communication will be tough sometimes. And I've seen it where I've had issues in certain cases in the past, and if the patient trusted me, I knew no matter what happened, I could get them. I could
I
get
don't, sorry
them.
about
No worries. I knew I could get them to our goal, regardless of what happens. Okay. If someone has no trust in me, suspects everything that I'm doing is very suspicious. I know no matter what, even if it is a really great outcome, they're not going to necessarily be happy. So for me, a lot of it is about communication and trust. And when we talk about difficult patients, I would say it's about communication and developing the right level of trust and relationship with a patient. And I think all of us care about our patients. We want awesome results, and we're savvy enough now to get them. It's just we know we need to avoid risks, and risks include making sure that the patient is a right fit for us. And I think that's the same um, for patients choosing surgeons. So let me go through the first advice that they give in this article, and I'd like to hear what you guys have to say about it. The first one is listen more, talk less. And they say everyone likes to talk about themselves, but the simple act of active listening with thoughtful follow-up questions will help you get off on the right foot with most folks. How do you feel about that?
makes sense. Every patient wants to feel like they're heard, that their concerns are being heard. I think that makes complete sense.
And that's
Yeah.
especially true if a patient is unhappy about something. Sometimes they just want to, say their mind. And a lot of times that just, diffuses a lot of things. And if you take the time to listen and not try to, cut in and interject, that makes a big difference. So I think that's a great suggestion.
Yeah. I mean, I think, what I try to do is I try to approach the consultation very open-ended. What can I help you with? Tell me a little bit about what's going on with you, and then I try to avoid for at least several minutes interrupting them and just letting them, say what they're concerned about.
I think sometimes it also means digging into certain things. So if I have a patient, say, who comes in and says, I want 650cc implants, instead of just doing it, it's a lot of it is like digging, like, why do you feel like that's something that you want? And they might say, well, my sister has 650cc implants, and that's exactly why I want them. I want exactly what my sister has. And then you sort of dig into, well, and you don't want to be a psychiatrist, but you also have to be like, okay, so what's your sister like? How does she look? What's your relationship with her? Like what's going on here? And sometimes you have to ask those follow-up questions and listen carefully in order to sort of dig into what the motivation for a patient is and what do you think will actually make her happy. Because if you just throw 650cc implants in there, I bet you, there's a lot of times they won't want that result.
And for our listeners,
I'm so confused by this example because everything is bigger in Texas.
That's what I was going to say.
I would say, they go all the way up to 800, don't you?
Yeah, for our listeners, 650 cc's is a large size. Maybe not in Texas. Actually, kind of think of it, maybe not in New Jersey either.
Everything is
just
bigger in
kidding
Texas
for all our
except
listeners,
your
It's
your
bigger in
income
Canada.
income state tax bill.
Yeah, jealous of that, aren't you? Yeah. Yeah.
Well, come up to Canada, you'll see.
Yeah. But it's no state income tax in Texas, y'all. It's pretty good. But I know what you're saying, though. What Sam is saying, and it makes complete sense, is you want to understand the motivation behind things. Are people motivated because that's genuinely something they want, or are there external pressures that are making them do things? Are there social situations that potentially might make them want to do things that we don't perceive to be in their best interest? And trying to understand that root cause motivation versus I just aesthetically like really big implants, is important to make sure you give people what they actually want. And you actually have the ability to make them happy. So that makes sense.
The next thing they said, I mean, we already covered be curious, which is what we just talked about, is find something you like about the patient. So let me ask you this. If you find the patient annoying or you sort of don't really click with them, are they still someone you choose to be your patient? Or is that sort of a red flag and you're like, I don't really like this person, so I'm not going to operate on them?
It depends. It depends on how annoying they are, because if they're really not jiving with you and rubbing you the wrong way, then there's nothing that's going to work. But what I find is that initially, if somebody puts you off a little bit, if you actually talk to them a little bit more and find something in common, or just figure out what their motivation is, a lot of times it turns out to be fine.
Yeah, I mean, I think a couple things. I mean, it depends on the gravity of the situation. I obviously do a bit of reconstructive surgery. So, I oftentimes give patients the benefit of the doubt in that discipline because, I'm there to help them, right? It's not an elective or cosmetic procedure. So the bar for cosmetic surgery is much higher in my. But I would say, me not liking the patient or being annoying or whatever is not for me to not take them on as a patient, but that annoyance or dissatisfaction or not gelling of the personality has to significantly, in my opinion, inhibit the communication. And so, for example, I may not, like somebody because, I don't know, maybe we have different political views. Okay. But that's not involved with the direct communication of me being their doctor. But if it's something like, you're explaining a process to a patient, and you've probably all had these patients that, some people just kind of sit there and say, yeah, when you're telling them something, which tells you that they're not listening. And then, it's that kind of thing is really, that kind of thing is really, really challenging to deal with as a physician, because that you're explaining that to the best of your ability and they're just completely toning you out,
Yeah. I think to answer Sam's original question, I think the interactions are a mirror in some sense. If I'm finding something in that interaction with the patient to be unpleasant, they're probably finding something in the interaction with me to be unpleasant as well. And unlike Sal, the other three of us do pretty much 100% aesthetic surgery. And so there's a selection process happening in both ways. I also recognize that as a human being, sometimes I bring baggage to the interactions. Sometimes I have to say that if I'm finding the patient something in the patient to not be to my liking, it's always distinctly possible that it's me that's the problem. And I'm very much open to that possibility. So if the initial interaction seems a little strained or a little awkward, much like what Larry was saying, I really try to make it better and see what I can do to improve that interaction, because I want to make sure it's not me that's causing that. And many times, almost every time, in fact, when the interaction doesn't, from my end, doesn't seem to have gone very well, patient generally doesn't select me to be their surgeon.
Yeah.
What would you say about, and this has given me pause. This happened, I don't know, maybe last year or the year before, where a patient said to me, "You know what, Dr. Rhee, I chose you because, I know you Asians are just so meticulous and careful with everything. So that's why I want you as my plastic surgeon." And I was
But you
like,
actually are. Yeah.
Well, that's
So
that's
I
fucking
mean, that's
true.
a fact. That's a fact.
What's
That's
the problem?
That's not a stereotype. That's a fact.
what's this?
Asians
Okay.
are very meticulous and very
Well-
exacting and excellent at calculus.
so
Fact.
so I mean, I was like, thanks, but like, I don't know if bringing a bunch of stereotypes to your consultation is really that awesome. So, I mean,
This
like,
is
is that an
a
insult?
man making
Was that what-
stereotypes about 650 cc implants. Literally.
Right, but Sam,
Huge.
is that a prejudice? Is that a prejudice if it's a compliment to you? Like, that's a compliment, right? I mean,
okay, what if they're like, all right, you be my surgeon, just don't be my Uber driver because I know you guys can't drive worth crap. So, like, I mean, where does that go? Like, right? So I'm not sure if that's a plus if they give you that kind of backhanded compliment like that. Okay. So, I mean, I've had my staff say, listen, that woman's perfume is horrendous. Like, it is so bad. I don't know. And and her nails are terrible and she's just dirty. And so please don't do what she wants you to do. Stuff like that. Like really odd, minor things sometimes. Like, does
Yeah,
that affect what you choose?
absolutely. I mean, and not infrequently sometimes we have patients that are actually, completely super sweet to me in the consultation. They are just like cooperative and great. They're ideal patient. And then the interaction with the staff is just absolutely horrific. And
Yeah.
from on the phone to the front office people to the nursing staff. And that's also a red flag. It's like, it's just, it's duplicitous.
Big word.
Yeah, I agree.
Yeah.
All right.
But for our listeners, Dr. Rhee really is very meticulous.
and
And he happens to be Asian, but those two things are not related.
and I'm not a great driver either. So all of that is true. So unfortunately, I fit the stereotype. Some of the stereotype, not all of it.
Just
All
take public transportation.
right. Okay. The next thing that they mention is practice proactive self-awareness and widen the gap. We can't control the feelings or thoughts that pop into our head, but we can control how we respond. Sometimes the most powerful way to control our thoughts and feelings about challenging patients is just to be aware of them. And remember, I might get frustrated, but I also know how to control those emotions instead of letting them control me. How do you guys feel
Yeah.
about that?
I mean,
Yeah, that's true. Sometimes you get patients who, like, especially when you were earlier in your career, that sort of trigger you. They'll be like, "Oh, Dr. So-and-so knows how to do it. Why don't you know how to do it like that?" So something like that. And then you just have to take a step back. You just tell, okay, well, I don't do it this way because this, X, Y, and Z. And you have to, if you're getting emotional about it, that's generally not a good thing. So you have to be aware that if you're getting, personally involved and feeling like, there's insults going around and you're taking it personally, that's not a good sign. You just have to be aware to, lay off.
Easier said than done. This is a very, part of being a surgeon is our personality, right? So it's I think it's challenging to emotionally divorce yourself from these kind of things. Sometimes you just have to really kind of bite the bullet, nod, and take a step back.
yeah, No,
Well,
it's interesting because I know all three of you guys very well, and I think we have very similar personalities. And Pacella, you may have had a similar thing like this when you were in business school, but when I was getting my MBA, we had to take a bunch of personality tests, try to figure out like what our strengths and our weaknesses were. And one of the things that came out was on a scale of 1 to 100, looking at patience, where like 100 is like Gandhi and 1 is like Genghis Khan. I got a 2. And the person administering the study said, you are exceptionally impatient, like multiple standard deviations beyond the from the mean. And you need to be aware of that. Like you can't really change the way that you react or you feel about things. You can change the way that you come across to others and the way that you control your emotions. And that was a huge light bulb moment for me because I realized that almost every time that I get impatient with something that's actually happening or with an interaction, it's probably me that's bringing the baggage to it and less so the other person that's actually doing. And that has changed the way I interact with other human beings considerably. I think I actively practice breathing methods to try to allow me to be measured in my responses. It's reflexive at this point. I do meditation like JJ McCarthy all the time now to try to control those things because ultimately, I think we bring a lot of baggage to the interactions with the patients because we're surgeons that are used to making split-second decisions, big cases, and ultimately, sometimes we have a lot of things we need to do. And so I think when
What about when you're rounding and your intern is not talking fast enough to give you this?
This was when I was a third-year resident and Dr. Pacella and Dr. Trussler were interns, and we had like 40 patients on a vascular surgery service, and they just wanted to joke around the whole time. But yes, I have now realized that the problem was me, not you guys. See, isn't that an eye-opener? I apologize to you and to Trussler all these years later. I am sorry. What? I hope you accept my apology.
Sam, I would say that that's the biggest change I've seen about you over the years is you are such an exceptionally quick and smart person. You never suffered fools gladly. Like anything that was really dumb or stupid earned your contempt like right away. But now, and I've traveled with you, I've seen you interact with tons of people. When you interact with me, like you have so much more zen and the things you say are so much nicer. I'm always like, who is this person? Like, this is not the Sam Jejurikar that I knew 10 or 15 or 20 years ago. Like, you've legitimately changed in such a positive way, and it's very, very impressive. Let me just put it.
What is that phrase you used to describe him? Fools what?
He never suffered fools gladly. Like he would just, if you were a dumb.
I don't even know what that means. That's amazing.
Yeah.
Well, it definitely describes you as well, Dr. Pacella. That's for sure.
Yeah, you have no patience for it. If there's an idiot, you got no patience for them. Let's just put it that way. Like, and I think most of us as surgeons, like we find that to be the case, and that's how sort of we were trained. But I will say this: I will have patients who, and this speaks to after, right? So maybe you've operated on somebody, so you're already wedded to them. You're connected to the patient, and I've had patients say, "You suck," or "Your results were horrible," or "I never should have gone to you," and you're right. It's very insulting. It's hurtful. But at the end of the day, I just look at it as, why are they saying this? What is it that I did, or what can I do to make it, to address the point of issue? And most of the time, if I find whatever that issue is and say, listen, let's take a step back. What is it that I can do here in this situation to help this get better? A lot of times the patient will be like, all right, I was really emotional. I'm really sorry. Let's take care of the problem. And I can get them to, generally, not always, but many times, to a place where we get out of that emotional situation and they get to a place where they're happy about it.
Makes sense.
Let's talk about the last one. Plainly state that you disagree. So at the end of the day, even if you practice all of these techniques, there will be times where you have to decline a patient request or demand. That's inevitable. They give an example about, I need a 6-month supply of my Adderall, or I'm not going to complete these drug screens, but I want my Suboxone prescription. Oh my God, these are horrible examples. So I thank God we don't have to deal with that, generally speaking. So
I want
how is it?
I want to be on disability for 5 months.
Yeah, exactly. That's
Okay.
something that's very common. So in those situations, how do you talk to patients in terms of disagreeing with them and telling them something that they may not want to hear?
I try to blame the California Board of Medicine. California Board of Medicine does not allow me to do that. I'm sorry. Which is not it's not lying, actually. There are several investigations into surgeons and physicians signing, falsified documents for extended disability time and extra narcotics, things like that. So there is some truth to that.
Well,
Yeah.
If somebody wants you to fill out some form or something like that, say, they need a handicap sticker or, something like that, you just tell them it's not appropriate. And then usually if you just say plainly and firmly, don't say with emotion, you say that's, that you don't fall into the category to get one of those or to get whatever you want. I think usually they'll be fine with it. Sometimes as a cosmetic surgeon, you feel like you're there to, provide service and you try to do the best job that you can. Maybe you're worried that, they're going to leave you a bad review if you don't do what they want. But, if you're right about something, you just have to stand your ground and not state it, in a way that's too harsh, but just state it as the thing says plainly. And I'm find that, patients generally will respond to that.
I had a patient one time who wanted me to sign a medical certification that his pit bull was a service dog. The surgery he had. And I'm like, this is completely out of my area of expertise. I'm not a veterinarian. I have no idea what this dog is, and that came out in a review online.
Oh, wow.
Yeah.
So
No, I've had maybe not that specific example, but similar examples of things like that ultimately come out in a review. But I think the thing is, we have to do what we believe is right. We have to do what we believe is ethical and not live in constant fear of a perpetual bad review. Because if you're a busy surgeon, which we all are busy surgeons, I think if we have 99% happy patients and 1% that are upset with it for some reason, that 1% is going to go running to Google, and that 99% will probably not do it unless they're prompted to. And that's just the reality of the world. There's some of our favorite establishments that we go to, whether they're restaurants or hotels, they have 4.8, 4.9 reviews, and that's you ultimately have to do what you believe is right and what is ethical. Yeah, you can't make a pit bull a service animal if you don't believe that that's the right thing to do.
Very good. Any other thoughts about difficult patients? Anything else that you want to sum up with before we go?
It's great.
Yeah.
Good discussion.
Yeah, I wish we had fewer challenging patients, but and I think as cosmetic surgeons, we've really gotten better at. Like you said, when we look at the people we trained with and how we deal with patients, totally different levels of communication, understanding, empathy. And I think all of us have probably become more empathetic with our patients as we've become more experienced with stuff. And we're a little better at sort of navigating the pitfalls of like Sal says, you can't find everyone who might end up becoming a challenging patient, but I think we've gotten a lot better with that, hopefully. So, all right.
Well said. Let's end this and sing Kumbaya.
I love that. Very good. All right, guys. Thank you so much. And until next time.